involved with RSN for nearly 15 years. Support from someone who's been there makes all the difference.
Hey David, what are you listening to?
Kidney Talk, an online radio podcast that talks about kidney disease and the prevention of it.
Oh, cool. Where can I find that?
Oh, you can download it on iHeartRadio, Google Play, and Apple Podcasts.
Oh, nice. I'll definitely have to download that.
Shout out to Renal Support Network, the annual Renal Support Network essay contest. I won the Renal Support Network contest last year, the Warrior, and we are all warriors. So thank you. Keep on doing all that you do, and be happy and healthy and keep the hope. Thank you, Renal Support Network. Woohoo!
As a kidney transplant recipient, I find that having an actual publication like Kidney Talk is an invaluable resource for any kidney warrior at any stage.
RSN keeps me informed of kidney advocacy issues so my voice can be heard.
I'm really looking forward to the prom this year and meeting people who are just like me. Dressing up is super fun and all the activities are amazing. Can't wait to see you there.
Hi, I've been participating in the Renal Support Network 30-minute fitness Zoom classes. Not only have I lost 15 pounds, but I can also strike a yoga pose like this.
When I created Renal Support Network back in 1993, I had no idea the impact that I would have among my peers. An illness is too demanding when you don't have hope, and peer support, education, and knowledge are crucial to our survival. We have a great week planned with some incredible speakers, great information for you to share, learn, so we can survive and thrive with this illness. It's imperative. So stay tuned. We're going to have a great event, and a shout out to our corporate mission partners for making this happen. And we're going to move on to Dr. Villicanna. I'm going to bring him up. He's going to be speaking about advancements in kidney transplantation. And I want to just mention, I want to give him a proper introduction, because I have to say that I really do believe that Dr. Villicanna saved my life. Oh. And the reason I believe that, he's going to be humble and say no, but I was in a situation to get my 4th transplant back in 2010, and I was listed with a center that was offering me a protocol that, when I look back, was not the right protocol for me. And I ran into Dr. Villicanna at a meeting that he was speaking, and he goes, please come and hear what we have to say. And when you don't feel good, sometimes you're like, oh God, I don't want to do that. I don't want to do that. I don't want to make another appointment and drive in LA traffic. But I did. And they gave me a different course of action for my transplant, completely different. And it just made sense to me. And when you have grown up at a transplant center and you got to leave it and you feel like it was worse than I felt like I'm breaking up with a boyfriend because I grew up with these doctors and everything. It was so hard. But I can say for certain, if I had not had that conversation with Dr. Villicanna when I had it, I do not believe I would have a successful kidney transplant today. And I'll never forget that, because it was so difficult, because I had people being tested for living donors at the center, and it inconvenienced a lot of people. But it is the best decision I ever made. So Dr. Villicanna is the medical director and transplant nephrologist at Loma Linda University. He is an RSN board member and just incredibly intelligent and a superstar. So let me introduce Dr. Rafael Villicanna.
Hi there. Thank you, Lori, for the kind introduction. Yes, thank you very much. It brings back some memories from back in those years. Let me share my screen. Can everybody see that?
We can.
It's coming out okay though?
It is. We can see it.
All right. So let me, just briefly, my name is Rafael Villicanna. Now at Loma Linda. I was at a different center some time ago where Lori and I crossed paths some time ago. I believe you've already had a session already this morning about maybe getting on the list, pre-transplant issues and concerns, and we'll kind of focus more on other things. So I'm going to talk about advances in kidney transplantation, and let me just make sure I got the slide sorter going. Actually, I'm going to change it to, there we go. All right. So just kind of a general outline as we move along the next 30-45 minutes. Just some general statistics about transplant. I think you may have seen a couple already this morning about that, so forgive me if it's a duplicate. We'll talk about advances in living kidney donation. Lori just mentioned, obviously she was a recipient of a living donor. We'll talk about that. Advances in deceased donor transplant as well. Advances in immunosuppression. There has been some changes, alternatives to dialysis and transplantation. And then just a couple slides like anything this year. It's, of course, there'll be a couple of COVID slides just to kind of go over things. All right, so this is not a surprise to many of you. I believe on the call that some of you have had a transplant, some of you would like one. This is not a surprise. Over the years, the amount of people who would like a transplant have gone up, and the amount of transplants have kind of been a little bit static, and definitely not caught up with the demand that is out there. But again, not a surprise. I'll be more specific about our, about Southern California in particular. But again, in the green line are people who are not active, purple is active, and then at the very top is everyone who would like a transplant. So it's just getting more and more, and unfortunately the availability of kidneys is not, unfortunately, caught up. All right, so I know everyone's been looking at maps this month in terms of, on the news and stuff and all this, but this is a different kind of map, although it's a map of our country, and there's different colors. The gist of this slide is just, unfortunately, there are geographical differences in terms of how long one will wait for a kidney from the list. Of course, if you have a living donor, that's separate and in parallel. But if you're waiting for the list, for a transplant, you don't have a donor. This is kind of what's happening. On this slide, the darker the color, that means the shorter the wait, or the more transplants there are available, and the lighter the color, the longer the wait. You'll notice California is a little on the lighter side, and that's something that we've been dealing with for quite a while. As many of you know, California does have a longer wait time for a transplant compared to other regions. There is going to be a slight modification, or a modification will be occurring in about a month. That should equalize things a little bit more, but there'll still, despite that, there will be geographical differences even when that new policy is enforced next month. All right, so this is this is my slide. This is just from 15 plus years of working in the region and being very involved in accepting organs for our list. And these are just kind of the wait times that one is, not to be a downer, but I'll show you what we could do to maybe make this better. But it's stratified by your blood type, of course, time on dialysis if you're already on dialysis. Thankfully, now nationally, one gets priority based on their dialysis time. I think you already maybe knew that or heard that today. So it goes retroactive to that, not when you come to the office or past committee. It's actually when you start dialysis for those that have already begun. But unfortunately, you'll notice about O is the longest wait time. About half of us are O. And unfortunately, that reflects kind of a longer wait time. So for standard offer, it could be up to 12 years, 8 to 12 years, depending, again, minus your dialysis time and so forth. But these are things that I believe some of you have already seen. And unfortunately, it's getting worse. When I first started working, I used to quote 4 to 6 years for O, and now it's 8 to 12, just to give you an idea of how out of control things are getting from that perspective. But not all is bad news. We'll get into some of the things that are happening. And so something that was actually a positive that I know RSN has taken notice and has helped kind of move this along is maybe some of you probably remember last summer of 2019, I think it was July, where the president did an executive order called the Advancing American Health Kidney Initiative. And what you'll recall is that there were different facets to this order that I'm showing you. Obviously, one, he wants to reduce the risk or the incidence of people with end-stage kidney disease, reduce CKD, all those things that will pay off, of course, down the road with less people having a kidney concern. And then in the middle column, they wanted to focus on more home modalities for dialysis, of course. So peritoneal dialysis, home hemo, we're going to start to get the spotlight. And then on the other, in the last column, increase access to transplant. That was a focus. So in the next 10 years, the initiative wanted to help double the amount of kidney transplants available for transplant. How would you go about doing that? I'll show you some info about how one could do that. Increase deceased donor organs, recovery, and importantly, reduce waste or discard. Some of you may have read, there's been some publications, I think early this year from Europe, basically comparing the amount of wasting of organs compared to our country, unfortunately. And there were differences. And so maybe ways to kind of learn from that experience. It's not really apples to apples per se, but there are some good lessons to be learned from, I believe it was France, who did that study. And then lastly, but not least, reduce disincentives to living organ donation and provide financial incentives to living donors. So basically, at minimum, not make it a costly endeavor for a possible donor. As you know, for those of you that have had loved ones, friends who wanted to help you out, and maybe they did donate, you know, there is actually some fiscal side effects from that, where, you know, that affects the ability of the donor to either proceed or makes them pause. But basically, it's a disincentive, and the idea is to remove that. So again, I'm going to show this slide a little bit later. It'll come back. I'll show it one more time just to kind of recap. Okay, the slide's a little bit busy. It just came out like a month or two ago, but so I mentioned the initiative, and it had obviously a focus on reducing CKD and stage kidney issues. It also talked about maybe more home modalities for dialysis. But now we'll just focus solely on the kidney component. And there's a lot of areas where there could be improvement. They talk, and then they in the green, and then the other color, maybe some of the barriers that need to be overcome to do that. But for those of you that have had a transplant or are familiar, you know that transplant is definitely not an individual sport. Lots of people who are part of the transplant program, and even outside our walls, not just our program itself, but we rely, for instance, in Southern California, we rely on One Legacy as our organ procurement organization. And I believe there are about 60 of those agencies in this country who have a government contract to do that. But there's different ways where we could basically increase deceased donors, reduce waste, maximize the gift that is being given by our donor families. And then, of course, increasing living donors. From a reimbursement perspective, getting rid of financial disincentives that make it harder for one to want to be a donor, life insurance issues, health insurance issues, all those things. So there's definitely targets where we could work on. But as you can see, it's not just one simple thing, but it's a lot of different groups that will need to come together to make this happen. And we should, actually. There's no reason why it shouldn't. So in the end, hopefully more kidneys available for those in need. All right, so we'll step back a little bit and just talk about the donors in general. And this is over a 17-year time span. And you'll see kind of at the very bottom, that kind of yellowish brown line, and that's living donors. It's kind of stagnant, if you will, right? It's kind of leveled out. It hasn't really gone up over the last few years, and there are different reasons for that. But part of it, there was during the recession that we had in 2008, there was a dip, of course, and it did recover somewhat, but not completely to what it was before that time. Deceased donors, though, you'll notice that that middle line, that has gone up a bit. And I'll show you a few slides as to why that's been happening lately, thankfully. There are more deceased donors that are families that are considering the gift and making that happen. All right. Back to living donor for the next slide. Few slides. I'm going to just solely focus on living donors. This is really the best way to either avoid dialysis or minimize your time on dialysis. Hopefully some of you on the call have been the beneficiary of a living donor. One thing that's interesting over the last 10, 15, 20 years is the relationships between the donors. So you'll notice at the top, kind of that purple color, related people, donors have gone down over the years. And that's an interesting phenomena. Luckily, though, it's been compensated by those that are unrelated, right? So friends, neighbors, people from church, they've kind of picked up the slack for related, as that's gone down over the years. I'll talk about paired donation. I have a slide or two on that. That's like the brown line that's kind of buried in the middle of all those lines. If you look closely, it is actually going up. So that's kind of exciting as well. But the gist of it is there are more people than ever that are donating to friends and family, and they do not have to be blood related. That we've known for a long time. And I think that reflects why there's a little bit less related donors, and why a lot of non-blood related spouses, friends, family, neighbors, all that. So that's kind of been a nice positive sign there. So although this may seem out of place, I just wanted to show you kind of a way we're trying to get more living donors. A lot of people are concerned about, genetics, right? About, oh, I don't want my family member to be a donor. I'm worried about them, and so are we. And so they would rather than not even investigate the possibility of being a donor. What I'd like to say is that there are now genetic tests that are being developed to kind of help us refine that question, like, is my loved one going to be at risk for what happened to me? And most of the time we can tell them, even without the test, like, no, it's not going to happen because it's not really a genetic issue as far as we know. But we need more data, be more specific. This test called the APOL1 genotype test, this gene has been found in African Americans to cause an increased risk of kidney concerns. And so this is a nice test that we've been doing as part of a broader genetic panel. And bottom line is we're trying to reassure more families, more donors when it is reassuring. And then, of course, be honest when there is something there that would make it a bad idea for them to not be a donor. But at the end of the day, we want to just maximize as many opportunities as we can to help everyone on our list and to help those that want to help others, right? The donors want to help. We want to help them get there. All right. So I mentioned the kidney exchange a few slides ago. But what happens, and maybe some of you listening in are in this situation, you're excited, your donor finally gets approved, right? It took a few months, you get that call, your donor says, I'm approved. But what if you're blood type incompatible, or what if you're tissue or HLA incompatible? Well, what do you do? The excitement now is wearing off because the first part is you got a donor and they're and they're approved. But then the second part, though, is that they're not necessarily compatible with you. So what can you do? Well, the options are either to wait for a deceased donor from your blood group, which could take a long time. I showed you a few slides ago how long that could be. So for most, that's not really an option. The second part is to do a donor swap or kidney exchange. They are now quite well known for over, for at least around a decade now. It's getting more advanced and more advanced every year. That's a nice option as well for those that can do that. And then sometimes there are other options. You can have a protocol that would allow you to undergo an incompatible transplant after having antibody-lowering therapies that I think have been discussed on RSN via podcasts over the years. So those are the options. But thankfully there are options. That's the key. Just wanted to show you. This is just a kind of a simple kind of illustration of how it works. They can get very complicated, kidney exchange. They can get very long, quite long. But the original was a two-way, but now it's evolved quite a lot. But that's the idea, right? Maybe your loved one can't donate to you, but they can donate to someone else, and you can also in turn receive a kidney as well as part of this process. So it's, in the end, everyone wins. They get a transplant that's compatible, that is better moving forward. So, and then this just came out, I think, a few months ago. There was kind of concern about the exchange compared to just like a typical living donation, and the outcomes. And the outcomes are excellent. They're very good. Whether you received your kidney via an exchange situation, or whether you received it, a typical traditional type situation. So it's been out for a long time, this theme, and it's working out very well. So now I'm going to be switching gears a little bit to talk about medications, and then I'm going to switch, I believe, a little bit further down on deceased donor kind of maneuvers that we're trying to do to have more transplants available for everyone who is waiting. So first we'll switch over to medications, which is like the bane of a transplantation, right? It's necessary for the most part. For the most part, I'll show you a slide or two at the very end where maybe that might be the case. But for those of you that have had a transplant, you're quite familiar. This is a courtesy of my partner who gave me this slide. And, these medicines have been around for a long time. Some of this might be going down memory lane for those of you that have been in transplant for quite a long time. So many of you will be on a calcineurin inhibitor, whether it's tacrolimus or cyclosporin. I'll show you a slide on that. Then maybe you might be on a second agent called mycophenolate mofetil, or MMF, or Cellcept. Imuran, that's for those of you that were transplanted in the 80s, will be familiar with that. Steroids plus or minus. Many centers use prednisone or steroids, a few don't. That's kind of, there's some variability there. Other classes as well of agents, but these are the medicines. And, unfortunately, they come with side effects, and it's not easy to take. And there's reasons why maybe it's not necessarily why everyone can adhere to that, because it's not that straightforward. So, kind of themes as to why it's so hard to take a medication after surgery. Either you're not taking the medication because you're just outright not interested, which is rare, I'll be honest with you. Life events, very important. Things happen and situations change, making it very hard. Sometimes maybe you lost your insurance, you had to leave the country or a state or whatnot. That does happen. People start to forget a little bit. The side effects, though, really are huge, and hopefully over time we'll be able to refine our therapies to where they're minimally, have minimal side effects. Cost, that's going to be a big. I'm going to show you a slide next on the cost, and then maybe the pharmacy issues. There's maybe partial adherence, again, where we skip a dose here and there. Unfortunately, the immune system doesn't forget for the most part. So unfortunately, that's the case. So medications are, unfortunately, at the moment, are here to stay. That could change, hopefully, with some new innovations in the future. But for now, for the most part, everyone will need to be on some type of medication to maintain their graft. So something that I just added last night, and I wasn't going to add the slide because it's kind of a confusing slide, but I wanted to bring up some of the legislation that's out there that will hopefully extend Medicare after 3 years. Some of you may know that after 3 years, your Medicare could be canceled unless you qualify for other reasons after transplant. The idea being that you've had your transplant, that you're doing well, you can get back into the workforce or whatever, and you can get your own insurance, and that's kind of the idea. So many of you know that that's, and many of us as well, that that's not always as straightforward as it may seem. And basically, I just had a conversation with someone who had a transplant 3 years ago, this month. So when I congratulate people on their 3-year anniversary, sometimes it comes with that caveat like, hey, how are we gonna go about in case you lose your Medicare? Is there another plan? What are we looking at? So this just came out this year, and basically it was a study to see if it was cost effective from the government perspective to make it a life, extend the coverage indefinitely. And the answer is yes. It is cost effective for CMS to extend this indefinitely instead of just at 3 years. As you can imagine, obviously there's a cost of losing your kidney, going back on dialysis of that nature. But the gist of it is cost effective. Even it makes sense, but someone did a study just to prove just that it is cost effective and actually adds quality of life as well. So for those of you that have had a transplant and have already passed the 3 years, you've already probably dealt with this concern, but thanks to the efforts of RSN and other groups, it does look like maybe this could happen, extension of Medicare after 3 years. And maybe next year, especially with if COVID settles down. There was a strong movement for this that I thought maybe passed this year, but with COVID, everything went sideways, as you know. So hopefully this will get revisited, and that Medicare could be extended indefinitely after your transplant. Okay, so the good news as well is that although medicines aren't ideal and they have their side effects, they have markedly reduced the risk of rejection over the years. You don't really need to focus on the names of the medications, but basically rejection was quite high early on, and you'll see nowadays it's like 10% maybe at centers. And thankfully, rejection doesn't mean that you lost a kidney. It just means that you need a little bit more medication to kind of get things back on track. But it has gone down markedly, as you can tell, over the years. So that's nice. So why does that happen? Numerous reasons. First of all, tacrolimus or Prograf, that came on the scene in the mid-90s, and you can see that how it pretty much has become the dominant medication over time at the expense of cyclosporin. Although I still use cyclosporin in special situations, I do. Tacrolimus or Prograf has definitely gone over that. Now, what else has happened? Let's see here. Other medicines in the mid-90s as well. Mycophenolate came on. That also helped rejection rates go down at the expense of the Imuran or azathioprine. Some of you may have been on that. Kidney transplant some time ago. For those patients who would like to have a family or conceive or are pregnant, we do definitely switch you over to Imuran or azathioprine, just so you know, because mycophenolate is not friendly to the baby. All right, and then this, some of you, maybe some of you are actually, sorry, let me skip the slide, are on this medication called belatacept. It does take the place of Prograf or cyclosporin. It came out about 9 to 10 years ago, and it has really nice long-term outcomes. Why isn't it being used on everyone or just about everyone? It's because it's first of all, it's an IV medication once a month, so it's not a pill. So for those, that's a plus or a drawback, depending on how you see it. And it had some issues when it was first approved, and it had some issues with early rejections. I believe that's been sorted out. But it's been on the market for almost 10 years. Many people who are on it swear by it. They love it, and they can bypass some of the side effects that the alternatives offer. So that changed a little bit. Okay, so in keeping with rejection and how it's gone down, I just kind of wanted just to highlight, and not to any particular product, just to be clear, but there are blood tests, basically, and maybe urine tests in the future that could suggest if there's something going on with your transplant, without always rushing to do a biopsy or not really knowing what's going on. There are blood tests that are available by numerous manufacturers. This publication that came out recently talks about 2 of them in particular, called AlloSure and Prospera. And bottom line, these are tests that are out there that we're using more and more. I do to help us kind of see how the kidney is doing. There's also gene expression testing that is out there. Again, a blood test by a different manufacturer that can also be giving us other ideas about how well or not well the graft is doing, even without having to rush to do a biopsy every time that there's a concern. So these are nice things that are out there. They've been on the market for maybe 3-4 years, and they seem to have more and more competitors joining that market all the time. So anyways, for those of you that are out there that have had a transplant and have already maybe had that test before or heard about it, that's what that is. So again, I told you I was going to revisit this slide, the American Kidney Health Initiative by the president last summer. Again, focusing on the right column, doubling the transplants. How would we do that? Well, number one, increasing living donors. Number two, though, maintaining your transplant. Right? Because if we can maintain your transplant a lot longer, that keeps you from seeking a second, third, or fourth transplant, right? So unfortunately, people on our list, many of them people have already had 1 or 2 transplants. So make that longer, last longer, so that's so that you don't need to go back on the list sooner than later. And then we talked about a little bit briefly about living donors. I showed you a genetic test that will hopefully clarify the status of many that would be a candidate. Maybe thought they weren't a candidate to be a donor, and maybe they are. So now I'm going to talk about deceased donors, and it's part of this initiative. And how can we increase deceased donors? Now I'm going to focus mainly on one topic, and maybe some of you hopefully have heard about this, but many of you have heard that hepatitis C donors are now being used in this country, not just for people who have hepatitis C, but to those that don't have hepatitis C, which sounds kind of strange if you think about it. Like, why would I want to get a new problem? Maybe I have a kidney problem, I need a transplant, and now I'm going to get a kidney transplant that has an issue called hepatitis C. So those that may not know, hepatitis C has been around for a while. It was identified formally in the early 90s, and thankfully, about 6-7 years ago, a cure came out. Not a treatment, but an actual cure, where it actually eliminates the virus forever. It's very effective. In over 95% of patients, they respond quite well the first time. So because the treatment is and the cure was so effective, especially in the East Coast, people started looking into the possibility of giving kidneys of donors who passed away with hepatitis C into people who don't have hepatitis C. And why would they do that? Well, number one is because there's a cure. Number two is because it would help get someone a transplant sooner. And number three, it would eliminate wasting of organs, which is the key, right? So this is kind of just attitudes of people who are on the list towards this topic, ranging back from 2006 all the way to 2018. So you'll see in 2018, there's actually like an increased curve in purple of people kind of thinking about it, saying yes. Now, it's not everyone who says yes, but there are more and more people who are going for it. And I'll show you quite a few more slides on this topic. So there's also regional. You might recall earlier that in this country, depends on where you live, there could be, the weights are different. And so geographically, there are going to be differences. You'll see California, at least our region, is darker. And that means that we were, even back then, people were open to considering, the darker the color, the more willing one was to consider a hepatitis C donor. But over time, this is 6 years later. Sorry, there's a delay there. There we go. So 6 years later, there's more darker areas in the country, you'll notice, compared to what I just showed you. And that just reflects, unfortunately, like the longer wait time, and also knowing that there's a cure. Because there was back in 2012, the cure really wasn't out there officially. But now that it's been out for use, you'll see more and more parts of the country are interested in this topic. And then this just shows you really how it's kind of skyrocketed, the use of these types of transplants. Not to say that there's some drawbacks, and I'll show you in a couple slides, but there's a markedly increased uptake of people willing to go for it. Why? Because of that breakthrough in terms of the treatment for hepatitis C, basically curing it. Let me see the next slide here. So this just came out less than a year ago. And they were basically, the gist of it, for those of you out there on the fence about this, maybe you've already heard this at your transplant center. Maybe you were obviously rightfully concerned. But they did a study where they compared people who either received a kidney with hepatitis C versus without hepatitis C. And their GFRs, or the measure of kidney function, at 1 year was literally almost spot on the same. Very, very similar. So their conclusion was that they have very similar outcomes at 1 year. And interestingly, nowadays, these types of kidneys go into people without hepatitis C who are waiting. Whereas maybe 5, 6, 7 years ago, the majority of these kidneys went into people who had hepatitis C already, so it was no big deal, right? They already had it, so they would get a kidney that had it as well, so it wasn't anything new that was being introduced. But nowadays, the majority of these kidneys go into people that do not have hepatitis C, and they get cured, of course, after transplant. Unfortunately, we're not doing a great job yet on this topic, although it's getting better. The kidneys are still being discarded or being wasted, although less. It's still happening, and this was from last year, although it's a little bit delay. It's like about a year old information now. But there are more. You'll see that in the gray. The gray bar in 2019, there's more transplanted kidneys, but there's still a fair amount in the dark bars at the bottom. That means that they were not used. So there's still some work to go on this topic, but this is kind of one of the revelations as to why maybe there's more deceased donors that are available. And again, for those that are on the fence about this topic, this slide, although it looks confusing, I just want you to focus basically on at the very end, which is the age. The gist of it is that those that do go for this type of donor, they're getting a younger kidney. On average, they're in their mid-30s versus early 40s for a kidney that is not with hepatitis C. So there are some benefits to considering this. All right. This came out also last year, and just kind of patient perspective on this topic, because it is kind of a newer topic. It's been a few years, but it's still kind of evolving, especially in the West Coast. And their conclusion was that the recipients of these experimental transplants, they seem to recognize the risks and benefits of these novel transplants and did not regret participating. So that was the key at the bottom there in the conclusion section, that they did not regret it. Another paper just came out more recently. That was this past summer. And again, this is about people patients who've had this. They went through this. They accepted a kidney that had hepatitis C, and now they're being asked about their experiences. And in the upper left, it's the reasons for accepting this in the first place. And many of them, the majority of them said a shorter wait list time, which is true. You get it sooner. That's really the biggest reason, of course, and they trusted the team's recommendation. Some felt that they were too ill or too sick to wait. That's kind of why they went for it. B, on the lower left, is what they were most worried though about, as they made this decision. And the biggest worry was of course getting the hepatitis C with that kidney, which many times it does happen. It comes with the kidney most of the time. Thankfully, of course, the medicine is started shortly thereafter, or sometimes even before at some centers, to prevent it from taking it in, and the majority will have no virus after a month after the transplant. So that was like their biggest concern for that. See upper right, after the surgery, post-transplant, what do they have any to fear? They're concerned, they had concerns about maybe transmitting it to their partner, which thankfully doesn't really happen. Transmitting it to friends and family, same thing. Those are some of the concerns. And luckily at the very bottom, it says no negative experiences. So about, I believe half of people did not have any concerns. But these are real life examples of people who went through this. And then overall in the lower right in D is where you're overall happy with. Was it positive? The majority, not all, but the majority said yes. The majority said, would they do it again? Said yes. And so the majority said they would do it. There are a few, not many, but a few that would probably say probably not. Not many, but the majority were happy with their choice. So this is kind of exciting because this is a way to get more kidneys available for our list. All right, let's switch gears. And I mentioned earlier in my conclusion, and I'm getting near the end of my talk, maybe some alternatives to transplant, alternatives to dialysis. This comes up all the time. Although it's now 12 years old, this paper and this experience, without fail, at least monthly still, if not more, someone asked me, hey, what do you think about that transplant where you don't take any medications afterward? Which is like the dream of most. And the people are still studying this. Although this has been in the works for 15 years, there are new studies that are out there, and some centers, including ours, we're in research where we're participating in protocols where one could be off of transplant medications altogether. So it's still in the works for those of you that are listening. I don't think it'll be mainstream just yet. But people are looking into this always to try to basically have a transplant without the baggage of the immunosuppressants or the medications. Okay. So again, there are roadmaps, so people are looking again into alternatives to make things better. And so there are people who are looking into things as to making things different. So what are the areas that people are investigating? Many of you have heard about either enhanced dialysis, the wearable dialysis unit, or the wearable kidney. That's been out with different investigators, getting government funding to investigate that. Implantable devices that I'll talk about, regenerated kidneys, stem cells, all those things. So people are definitely looking at this. People are actively really wanting to get there to have more alternatives to what we have at the moment. Again, at the end of the day, you'll see at the top, it says improve patient quality of life. That's really what that amounts to. That's really why this is being looked into. But again, different things that people are looking at. I'm going to focus though. I mentioned I get asked about the transplant without many medication, like on a monthly basis. This one I get asked about on a weekly basis. So this is the implantable artificial kidney that is being looked at by a few groups. It's still not available, but I think it will happen. Some time ago, when I was training at UC San Francisco, that's where one of the lead groups began their research, and they brought this up even back then. But they continue to refine it. I believe it will come to fruition. It's getting closer and closer. The beauty of this is that there are no medications that will be required if you receive this type of implant. So no medications will be needed. The drawback is that they don't know how durable it will be, so it may need to be replaced out once a year or whatnot. And then lastly, in terms of the actual kidney function that it does provide, it doesn't say provide the amount of kidney function that like a good living kidney donor would offer, but it's enough to keep you off dialysis or get basically to avoid dialysis. But it's fascinating because there's a lot of interest in this in many settings, and this you will definitely be hearing more and more of. It's getting closer. It's just not there yet. All right. So these are the groups that are looking at this. There are lots of groups. I mentioned UCSF, and I believe they are partnering with Vanderbilt. They're doing that. And there's other, especially in Europe, there's a lot of interest in this. These are just different groups that are looking at this, and bottom line, it's going to happen. It's just a matter of who's going to get there first and what will it look like. Let's switch gears. I'm actually wrapping up now. A couple more slides, but COVID. Obviously, it's impacted everyone in different ways. And this slide just came out a couple months ago. It talks about COVID, how it impacted centers from May all the way to August. The gist of this slide is that the darker colors means that the centers were not really that active. So if you see dark circles, that means that they were not doing as much as they normally do. And luckily, if you just focus on August, you're going to see a lot more lighter boxes and shapes, because that means people are pretty much back to either 100%, many even, or at worst 50%. But the majority are 50 plus. Whereas in May, you'll see there was a lot of darker colors. Some of them were 0 to 25%. You don't see as many 100%. There were a few, but not as many. For us in particular, by May, we were definitely, I'd say at least 75% towards 100 in May. And of course, June, July was like 120% to make up for everything that didn't happen in April, really. But I'd say we're pretty much back online, thankfully. And I think that's the case for most of the centers in our region. So telemedicine. This is, I'm sure many of you have done this already. We're kind of doing it in a different way, obviously Zoom. It's not the easiest, but it's kind of neat as well. It has some benefits, especially those that live far, and hopefully this will stay, even when the pandemic does resolve. I'm sure it will stay in some capacity. There's just challenges though, from the center, from the patient perspective, but I think it's been working out and people are getting used to it. But this is probably something that you've all dealt with in some shape or form. In general, we do like to see people in the office for the first few months after surgery. That never did change even during the worst part. We thought that's really key to try to maintain that. But after maybe 2, 3, 4 months for sure, we've been flipping over to telemedicine for the majority of people. It's been working out. Again, this is just more for COVID. One thing, and I just right before I joined the group, I did actually a telephone visit with someone who basically asked me, what happens if I get COVID? I've had a transplant. What's going to happen? Because there's a lot that happened in the media, of course, at the beginning, and a lot of maybe not great experiences when it first all, hit our country in the spring. But what I want to tell you is that many people who've had a transplant and had COVID, many of them never even went to an emergency room, never, maybe an urgent care, but most of them did not get hospitalized. That's why I want to really reinforce that that it's not all doom and gloom. Even if you do get it, the majority of people are at home, they're recovering, they never even were hospitalized. At least that's been our experience here. A couple days ago, there was someone who sounds like he had it. He's getting better, but for 3 weeks, he didn't want to even look to see if he had it because he was worried that he would go in the hospital and he thought bad things happened to people in the hospital, and that was that. So that's one of the drawbacks of COVID is that we tend to forget ourselves and take care of ourselves. Remember, you got to think of yourself, take care of yourself. It's not all doom and gloom. The majority of people who have been affected with COVID, who had a transplant in my program, were at home. And sometimes I find out like a month later, like I'll see them on Zoom and they'll go, "Oh, I had COVID." I'm like, "Really?" And and they look great. And their numbers, I could never tell. Their kidney never noticed. So just letting you know, it's not all, if it does happen to you, please take care of yourself, quarantine, things, the typical things, but they do work actually. They do work and people get better. All right. I think this is my last slide. And just wanted to wrap up saying that there are new initiatives to stimulate more kidney transplants. our current president did roll that out nicely last summer. Because of COVID, it got stalled a little bit, but groups like RSN were definitely making headway into making this a reality, and I think it's starting to play out already. Deceased donors are more available. Hepatitis C, I use that as a good example. Acute rejection rates have decreased over the years. Thankfully, there are new blood tests on the market that could help predict or detect kidney transplant injury. That's nice. Alternatives to transplant are being explored. The artificial kidney in particular, I showed you a couple slides on that. And then I reported our COVID experience, not just nationally, but personally on our programs. But most of us thankfully have recovered, some of us for quite a while now. And with that, I wrap up. Thank you. I think that's it. Yeah, sorry.
I got it. Thank you, Dr. Villicanna. We have a couple of questions for you before we move. And you know what? Thank you for sharing the COVID information. I mean, because, you know, we all get scared about it. And, you know, of course, we don't want to get it now that there's a vaccine out. You know, we have an opportunity to be able, you know, not to play Russian roulette, I guess.
Exactly.
You know, so it's good to stay safe and wear a mask. And I've been doing everything I can. But a couple questions, I think you may have answered these, but I'm just going to reiterate them. If you have a blood transfusion for severe anemia, do you always get antibodies? And I know that one, but I'm going to let you answer that.
So, yeah, you do definitely know that personally from experience. You know, interestingly, not everyone who gets like a blood transfusion gets antibodies, but many do. But not every. It's not 100%. But it is a risk factor for developing HLA antibodies, pregnancies as well. I've seen someone who has had 6 pregnancies and had little antibody, but then someone who had just 1 pregnancy and has almost 100%. So unfortunately, it's not always like linear or direct, but you're right. Blood transfusion does increase your risk for antibodies. Thankfully, it's not everyone, but the more blood transfusions you get, especially if you're younger, at a younger age, and yes, unfortunately, that's true.
And I guess any other, there's a lot of questions on Medicare and eligibility, and I think that's a whole other, that's just a whole other ball of wax, isn't it? And I think that, you know, many people don't realize that Medicare is an entitlement program for people with kidney disease. And when the government signed it into law, they said they'll cover a transplant up to 36 months. So we have this new bill coming out that could possibly be passed. I'm trying to figure out which one is being hold on, I'm sorry. If this bill passes, which there is a chance it will pass, but it's only for the medication. It's not for the doctor visits and the blood lab draws. So, you know, I think it's going to help people have access to lifetime immunosuppressant drugs, but you still need your blood drawn and you still need to have the doctor write the prescription. So that has been my little bit of a, you know, like frustrated because it may not help certain people.
Right.
If you can't get access to see the doctor. I mean, we need regular care because usually something else gets us, like an infection or something.
No, absolutely. And the reason I even brought it up is because I had a conversation yesterday for someone who moved to the Northwest and is having the 36-month mark this month. And he's working, and as a matter of fact, he was on a job and he took the time to take my call. So, but good point about it. Even if it does pass, that it'll cover the medications. Hopefully, it'll be when it does get approved and finalized. It does take in consideration what you mentioned, because obviously you have to measure things, you have to monitor, and like you said, infections are common, and making sure that we're not overdoing it as well, because we can definitely overdo it with our medicines, and hopefully that.
Yes, I heard a story once, a sad story, but somebody who decided to lose a lot of weight, which was great, but they didn't get their labs drawn. They didn't get regular blood tests, and their labs went so out of whack, they lost their transplant because of toxicity of the medication. So it's so important to be regularly monitored. And there is one question, and once you get a transplant, you sometimes need dialysis afterwards. And that's normal, right? Sometimes the kidney just is sleeping a little bit and taking a nap.
Yeah, I think that's in the Q&A question, right? I think
Yeah.
Yeah. So for a deceased donor, it's common. For a living donor, not so much common, but not so common. But for deceased donor, at least in our region, I'd say at least a third of people who had a deceased donor transplant will require at least one dialysis treatment during the transition, at least one. And when it does happen, I'd say the average duration is about a week when it does happen. But thankfully, it resolves and move forward as if nothing happened. But that is part of the issue with taking kidneys from all over the country, being on ice or something of that variation, and being out of between people, right, between the donor and the recipient. But yeah, it's very common.
And the last question is, can you please explain the test APOL1?
Yeah. So the reason I brought it up is just because over the years for living donors, we've always thought and continue to believe, but that donation was incredibly safe for all, and it usually is. Unfortunately, over the last maybe 5 to 7 years, investigators have identified a few groups of people who maybe don't do as well after donation. They were trying to figure that out a little bit more. In the end, it was felt that not all the reasons, but some of the reason would be genetic. And in the African American population, basically, they were, especially young African American males, were the highest risk of being donors who then themselves had a kidney problem in the future, which you don't want. And so APOL1 was discovered some time ago, but in the kidney world, it's been discussed the last 7-10 years with more and more frequency and intensity every year. But it's basically a gene that developed in Africa, actually as a protective, it's supposed to be protective against African sleeping sickness. So it protects you, actually, if you have that. Unfortunately, it also brought along an increased risk of kidney problems, whether it's chronic kidney disease, end-stage disease, focal segmental glomerulosclerosis, FSGS. That's kind of what that came with. So now we know we can check whether a candidate, a donor candidate, or even I do it on recipients who want to know if they have friends and family who want to donate, they want to know for themselves. I will check that status. If they have both genes, they're at risk. If they only have 1 or 0, they're not at risk. There's 2 genes, and you have to have both. And if you only have 1, you're okay. 0, even better. But 2 is the one that gives you the risk.
Well, that's more information that we can know about the donor is great. And it's interesting, if you donate a kidney, and we have, I think one of our members is on right now, but he donated a kidney to his sister, and then lost his transplant. And his kidney function, he donated in the 80s, and they didn't test as much, and he had high blood pressure and different things. But he got a transplant within 2 weeks of being listed. He never went on dialysis. So you go to the top of the line, which is the way it should be.
Absolutely. And one thing that I kind of never realized, but I learned in the last year, is kind of similar to your example of someone donating in the 80s. A gentleman donated in the 80s to his sister, and then developed problems. And then I met him when he received a transplant in 2007. And that kidney lasted him, up until at the beginning of this year. And within a month or 2, he received his second transplant. So bottom line, though, is that it's forever. Like, once you're a donor, you will receive as many transplants as you require during your life, and you don't wait. You will maintain your priority. I thought it was only just for the first one, because I never thought of the second one. But actually, it extends forever, which is nice.
Oh, that's incredible. And there was one last question. We're running a little bit over, but they asked if they had sometimes you get two pediatric kidneys because of the size. How do you tell if they're both working and you got your money's worth?
So thankfully, the ultrasound is a good way to look at both. Interestingly, I've seen, because they're so delicate, those donors, the pediatric donors, and that's why they do both. Sometimes I've seen where one of them doesn't look like it's really functioning much at all, but that other transplant begins to mature and evolve, and the numbers look like as if they have one complete, well-working transplant. So that's how you know. An ultrasound is probably the best place to start.
Well, terrific. We're going to thank you so much, Dr. V. He's the medical director of the Transplant Center of Loma Linda University, and you went to that program, I think, how many years ago? You've really been, got a new transplant facility, and I know a lot of people out in that area didn't have a lot of options. They were traveling, so it's great that people don't have to stay in LA Riverside County traffic, because it's a nightmare. Thank you so much for your expertise, and we'll see you soon.
Thank you, everybody. Appreciate it.
Have a great day. And a shout out to our corporate mission partners for making this happen.